Hello, everybody. Thank you for joining us for this EGDRC seminar. Today we have Dr. Christianne Roumie. She's a professor of internal medicine and pediatrics, the Institute for Medicine and Public Health at Vanderbilt University. Dr. Roumie has developed research programs related to comparative effectiveness research designed to improve health outcomes by developing evidence-based information for patients, clinicians, and decision makers about the most effective interventions for patients. Dr. Roumie has been a leader in the field of medication prescribing and cardiovascular epidemiology and improvement. Her work is focused at the intersections of clinical epidemiology, patient outcomes, and dissemination science among patients with hypertension, diabetes, and cardiovascular disease. A critical aspect of this mission is to provide evidence-based care for therapeutics, including medication prescribing. Dr. Roumie, you can take it.
Thank you so much, Wendy, and it's a pleasure to talk with you guys today. And I hope that will provide some information on our most recent grant funding and hopefully help you guys to tailor your practice. So our work is funded by the VA, and the authors are responsible for its content. Our goals and objectives today are really twofold. The first is to describe medications that are often used for the treatment of diabetes, including risks and benefits. And most of my work does use observational methodology and research to answer these questions. So really understanding the limitations of observational research design. So our outline will go through some of the regulatory history of diabetes. We'll review some of the newer agents. I will talk about MACE and heart failure. I'm not going to talk about fractures today, but I'll talk about peripheral artery disease and give you a little taste of the kidney disease work we're doing. So most of our medications are approved based on clinical research, which is really laid out by the Food and Drug Administration in 4 phases. So what the pharmaceutical industry needs to do to gain approval is really provide evidence based on the first 3 parts. So phase 1, looking at safety in healthy people. Phase 2 really starts to look at does it work or efficacy, but typically those trials are in less than 300 people. Phase 3 is really still about efficacy, but approaches effectiveness. So typically it's 1,000 people or so, and typically those trials are short. Phase 4 is not required for drug approval, but are post-marketing trials, and they're really the larger studies in more general populations. So what we know about clinical trials is that the comparisons often placebo. They are typically small. They are short. They are selective of their patients that are not necessarily where the drug will be used when it becomes widely approved. So prior to 2008, the FDA approved diabetes drugs based on a 0.5% reduction in A1C, which is a surrogate outcome, as many of you know. There is a public health post on why RCTs are given the gold standard status, but they also have their limitations. So all that glitters is typically not the best part of the clinical trials that we are all basing our data on. So diabetes medications are really growing in complexity. And for a very long time, when I was being trained clinically, this is really where we were up through metformin, 1995. But then really since 2006, there's been an explosion of medications, including the GLP-1s, the DPP-4s, the SGLT2s. And in 2022-23, the first combo GLP Dual terzepatide came out, which many people know are highly effective. So why do we have such a complicated diabetes medication history? So we should look back at our history, at the historical foundation. So metformin is derived from French lilac and for years was used as a folk remedy for diabetes. The anti-hyperglycemic moiety is called guanidine, and homologs to guanidine are hepatotoxic. It was first approved in the UK in 1958 and introduced in the US in 1959, but was not approved. There are 3 derivatives of the active ingredient: fenformin, which was approved and used in the United States; metformin, which was used in France and the UK; and buformin, which was used in Germany. Soon after the approval, fenformin and buformin demonstrated a very strong relationship with lactic acidosis, which led to their withdrawal in 1977. So this is Ralph Nader. So in that same year, 1977, his research group, which was called Public Citizen, started pressuring the FDA about fenformin and the concerns to lactic acidosis. But because metformin is renally cleared, the thought was to limit the use of metformin to those with normal renal and cardiac function. So it was approved in 1994, but from the very start had a black box warning regarding lactic acidosis and restricted the use in patients with kidney disease and heart disease. Fast forward to 2008, and we see federal hearings surrounding cardiovascular risks and associated with rosiglitazone. As a result of the congressional hearings, there was loads of finger pointing, and the FDA was required to develop cardiovascular guidance for medications that treat diabetes. So the guidance included recommendations that for new phase 2 and phase 3 studies, you don't just collect hemoglobin A1C, but you must also collect evidence of heart attacks, strokes, and revascularizations, what became later known as MACE, or major adverse cardiovascular events. The recommendations that were put forth to the pharmaceutical industry were to test two-sided confidence intervals for MACE. So that specification was to test if a new drug wouldn't be harmful, but also could test for possible benefits. Much of the research that we know has shown that it's really not enough to lower hemoglobin A1C, but how it is lowered impacts clinical outcomes. So glycemic abnormalities, elevated insulin levels precede the development of cardiovascular disease, heart failure, and kidney disease. So medications that reduce hyperinsulinemia can sometimes delay end organ effects. This is a really simple review of how these medications work. Metformin is a complex biguanide. It can improve metabolic profiles, including reducing insulin resistance, but it can also inhibit hepatic gluconeogenesis. Sulfonylureas stimulate insulin secretion from the pancreatic beta cell, resulting in hyperinsulinemia and possibly more resistance. DPP-4s increase incretins, which inhibit glucagon release, but increase insulin secretion. SGLT2s work in the proximal convoluted tubule to prevent reabsorption of glucose and facilitate its excretion in the urine. Glucose is also excreted and increase the reabsorption of phosphate, which can increase PTH and bone turnover. GLP-1s bind to the GLP-1 receptor and stimulate glucose-dependent insulin release, so improved sensitivity. It also slows gastric emptying and suppresses glucagon levels. Because these drugs were all approved after I finished medical school and residency, I find that I have to continuously remind myself of what they do. So I kind of look at this kind of quick chart. The columns here are the drug classes. And in the second row is the typical medications. The third row is kind of some of their improved effects. And then kind of at the end, some adverse effects that have been demonstrated. Really what I want to point out is that all of these newer medication classes cost over $200 a month for a 30-day supply. And that is really hard for a lot of patients when you're talking about a chronic medication that they're going to use for the rest of their life. This is kind of out-of-pocket costs for SGLT2s with insurance can vary up to $500 a month. And there is a much lower cost for medications like Ozempic out of pocket across the globe, including in Canada and in Germany, compared to the US. And DPP for patient level costs are between $150 to $200 a month. So there were a lot of these pivotal trials that demonstrated that MACE and heart failure were reduced, and there was improvement for patients who are on SGLT2 or GLP-1. I think the biggest thing I want us to kind of walk away when we reviewed the literature back when we wrote the original grant in 2019, the biggest problem was that these populations were enriched for patients with prior cardiovascular disease. So if the FDA tells you you have to monitor cardiovascular outcomes and you don't want to have a clinical trial for 20 years waiting for people to develop cardiovascular outcomes, the easiest way to do that is to enrich it with people who have prior cardiovascular disease. So as you can see, most of the original pivotal studies that these medications gained approval on were enriched more than 50% with patients with underlying cardiovascular disease. So when we originally proposed the grant back in 2019, we told the VA, well, this is what the diabetes guidelines looked like back then, which was assess for the A1C and assess for presence of underlying heart disease. And if they didn't have heart disease, then start them on metformin and understand risks and benefits. This is the guidelines now, which are a lot more complicated and really skips the metformin step in a lot of patients now, despite a long history of evidence that metformin works well. So I like to review the Geriatric Society guidelines because the VA guidelines are very similar to that. Before I start escalating somebody's medications, I really want us to think about, well, where are we going, right? So what should the goal be for many patients? And for many patients, the hemoglobin A1C goal should be closer to 8% because they're elderly or they already have advanced comorbidities, including, microvascular complications. So they may have a markedly reduced life expectancy, and it is not necessarily worth all the costs and the complications to the patient to push their A1C down to 6.5%. So our aims were to answer the clinical questions that among patients with diabetes, what are the absolute risks of adverse events and the potential cardiovascular and renal benefits for those who add an SGLT2 or a GLP-1 compared to those who are adding a DPP-4? And is there a difference among those with and without prevalent heart disease? So aim one, which I'll talk about today, is looking at a 4-point MACE, which was AMI, stroke, cardiovascular death, and heart failure. Aim two, which I won't present today, but I'll give you kind of the bottom line on that, is to look at fracture rates because of this theoretical loss of calcium phosphate product with SGLT2s. Aim three is to evaluate amputation and peripheral artery disease. And aim four was to evaluate CKD progression and all-cause mortality. So our data sources include the corporate data warehouse, which houses all of the VA inpatient and outpatient encounters for all VA provided care. All of that is linked to Medicare for those who are 65 and older, and to Medicaid for those who are eligible to receive Medicaid benefits. We also link to the National Death Index to get the date of death and the cause of death for patients. And then we have all of their pharmaceutical usage. So all of the medications that are filled within VA, inpatient and outpatient, as well as through Medicare Part D. And we had IRB approval with a waiver of consent. So we use a type of design which is seen more frequently now in observational epidemiology, which is called a trial emulation approach. The first step is really articulating a question for which a hypothetical RCT would provide the answer. So your protocol has to specify certain key elements that define the causal estimands. So what are the eligibility? What are the treatment strategies? Who gets what, like treatment assignment, start and end of follow-up, your outcomes, and the causal contrast. And then the next step is explicitly emulating the protocol using the observational data. So you find everybody who's eligible, you assign them to treatment strategies, and you follow them up from the time of assignment, which is really your time zero, until an outcome or end of follow-up. And then you would conduct that corresponding analysis in a target trial. Except that what you're doing is you're adjusting for baseline confounders in the same way that a clinical trial assumes that your baseline confounders are randomized, and so that you are accounting for measured and unmeasured confounders. You would attempt to control for those baseline confounders to emulate a random assignment. So in this example, I'll focus on GLP-1s versus DPP-4s. So the target trial randomizes a patient to start a GLP-1 or a DPP-4. It recruits all patients who are eligible through December 30th, 2019. They are included if they are users of metformin, insulin, or sulfonylurea. So we said they had to be using it as an add-on therapy. Outcomes are collected passively, so patient can't really withdraw from the study other than falling out of the VA or Medicare or Medicaid health system. Patients can stop or change the therapy as their providers think is appropriate. So what we are estimating is the relative biologic efficacy of the medication. So really, we're looking at the time they're on drugs. Is there an association with the MACE outcomes? In an intention to treat, we basically go to you're assigned to the medication, and regardless of your adherence, we will assess you as a user of that medication. So our target trial requires the provider to believe that both medications are reasonable, which would then shift the covariates for the patients whose provider had a strong preference on which medication they should prescribe. So this is what our study design looks like. We have patients who enter at the time they're first diagnosed with diabetes. They enter into the cohort, and we follow them along until there is a new prescription for DPP-4 or a GLP-1 or an SGLT2. And that's their index date, or essentially the date of the coin toss or randomization. To be eligible to get to this point, we said you had to be a new user of that medication. You couldn't have previously used it. And you had to be on metformin or sulfonylurea or insulin. And we didn't want you to be a switcher. So, for example, if you were using GLP-1 and let's say you had side effects or a poor response, and then you started SGLT2, we basically said, well, their follow-up event rate may be due to withdrawal of one drug or the initiation of another drug. So we basically created a washout period. So you couldn't use any of those drugs in the prior 90 days. And then we always calculate diabetes duration as the time from your earliest use of any medication till the time you were randomized. So you had to be 18 or older, have type 2 diabetes, be an active user of the VA, prescribed insulin, metformin, or sulfonylureas. We excluded those on hospice, dialysis, or transplant. And then we also stratified by prior history of diabetes. So we follow people along in persistence windows. This is their time on drugs. So this is what I was referring to as we were looking at the relative biologic efficacy. So it is similar to a per protocol analysis in which we are trying to minimize misclassification of time on drug. In this scenario, patient A, if you can see here my pointer, gets let's say a 90-day drug supply, and then on day 89 refills that drug supply and has another continuous 90 days. There's no gaps in their medication use. But that's not often what happens in the real world. So often you might have a patient who gets a 90-day supply of a medication, and then they missed a couple of days, and then it takes them about a week to get into the pharmacy to get their refills, and so they have a little gap between their intercurrent fills. We said if you went for over 90 days, so on day 91, you got censored as a non-user. Again, these medications for diabetes are chronic medications that should be taken every day. We also calculate this for injectable medications, including insulin and the GLPs. But really, if you go more than 3 months without the medication, it's probably true that you're not necessarily taking that medicine. All right. Covariates. We have a lot of covariates in the data that we account for, including demographics, comorbidities. The nice thing about the VA data is we have clinical and laboratory values. We have all their co-therapies. We have their social history, other illnesses, time trends, their healthcare utilization, and use of other high-risk medications. So the first issue that we discussed to help emulate this clinical trial is to address an issue called confounding by indication. So certain patients are more likely to get a drug regimen based on their characteristics. And our goal is to balance patient characteristics in the same way that randomization would have balanced their characteristics. So to do that, we use a tool called propensity scores. And in these models, the probability that you are a user of GLP-1 or DPP-4 is based on your characteristics. The area in orange or solid orange is based on those who only use GLP-1. The area in solid gray is based on people who only use DPP-4. As you can tell here by the size of the models there, that we have just a lot more DPP-4 users. This is frequency on the y-axis than you do GLP-1 users. But that area of overlap are people that have clinical equipoise, where the provider said, well, these characteristics are similar enough to the other characteristics where they could have resulted in any medication or either of the two medications. All right, so there's a lot of ways to use a propensity score, as many of you know. We have DPP-4, the size of that cohort is 4 times as large as our GLP-1 cohort. We could have matched them to each other, which gets rid of 3 of the DPP-4 users. So we just keep a 1-to-1 match. Or what we ended up doing was using inverse probability weighting with the propensity score to avoid excluding individuals from the analysis. So everybody gets to be part of the analysis, but we upweight or downweight patients based on the medications and their covariates. So our analysis used a Cox proportional hazards model with a time to event in the propensity score weighted cohort. The primary analysis was the time to the first composite event, which was the MACE and heart failure event. And we used cumulative incidence plots to show the cumulative events with bootstrapping of confidence intervals. So this is Lee Richardson, who is a cardiology fellow at the time that we worked on this. He is now faculty up in Louisville, and he helped to lead this with our group. So we start out with over 2 million unique veterans, and then about 500,000 fill a first hypoglycemic med of one of the meds under investigation. And remember, this data was only through 2019, so a lot more medication use in the more recent years. And then when we looked at people who switched, we excluded about 80,000 who had other drugs in the washout period. And then we go through and we make sure people don't have our exclusion criteria. And then since we were primarily interested in primary prevention of MACE, we did a confirmatory analysis for those with cardiovascular disease, but they were excluded from the primary analysis. So just to show you how propensity score weighting works, we had 124,000 DPP-4 users and 37,000 GLP-1 users. And the mean age was similar, but you can see we had a difference in the number of years the medications start to the index date. This is like their diabetes duration. So people on GLP-1 had a longer duration of diabetes. more often, they added it on as a third line agent. They were heavier with a body mass index that was closer to 36 compared to the DPP-4 users, and they had a higher hemoglobin A1C. They were also more likely to have congestive heart failure. So after propensity score matching, we have about 28,000 in each group. And I'll just point out that our diabetes duration is now matched at about 8.5 years with a very low standardized mean difference. This is not a p-value, it's a standardized mean difference, which is basically the difference between the two groups. So anything less than 10% is good. And you can see all of our standardized mean differences are very low after weighting. So in the primary prevention cohort, I'm going to use the same format for most of my slides, where the event rate per 1,000 person years of use is on the y-axis here, and the outcome that we're monitoring is on the x-axis. DPP-4 will always be shown in gray, GLP-1 in orange, and SGLT2 in blue. So in our primary prevention cohort, we found that for the composite of MACE and heart failure, there was a much lower event rate for GLP-1s compared to DPP-4s, and that was universal in hospitalization for AMI and stroke, cardiovascular death, and in heart failure hospitalization. When you look at primary prevention for SGLT2s, we did see lower event rates. However, because of our sample size and wider confidence bounds, this did not reach statistical significance in any result for primary prevention except for heart failure. So when you look at the primary prevention cohort, you see the adjusted hazard ratio was 0.82 with a risk difference of 3.2. So that's 3.2 lower events in the GLP-1 group compared to the DPP-4 group. For SGLT2s, the adjusted hazard is lower for SGLT2s. However, confidence bands were overlapping. When you look at the full cohort for both primary and secondary prevention, again, if you think about both groups, for MACE and heart failure, they're both showing lower rates for GLP-1 or SGLT2 compared to the DPP-4s, lower rates of hospitalization, death, and heart failure hospitalization. And that's what those cumulative incidence curves look like. Panel A and C are for no history of cardiovascular disease. This is essentially that same curve that I just showed you, where there's really a lot of overlap. But when you look at the SGLT2s and the GLP-1s, among those with a history of cardiovascular disease, you see a very nice separation of the curves, and it is the effect is much more prominent. Okay, I'm going to briefly tell you there's no risk of fracture, or we found no association between fractures and SGLT2 use. And then I'm going to just skip over and talk about Katie Griffin, who is an MPH student. And this was her thesis project working with the team. And she led the part on peripheral artery disease and revascularization. So her composite outcome was more broad than just amputation, which is what was followed in most of the clinical trials. And she said, well, by the time somebody gets to amputation, they've already typically had revascularizations for their peripheral arteries or had stents put in. So we looked at the time to a first surgical date as a composite outcome for any one of these three outcomes. And then we looked at it as individual outcomes. So one of the next things that does come up with amputation is that there may be informative censoring. So for example, if somebody comes into the hospital and they have an infection or gangrene, as soon as they come into the hospital, they might then have an amputation on their great toe. The first thing somebody might do is stop their SGLT2. And oh, well, they don't heal. And 25 days later, they might have a second amputation at the midfoot. So this created some challenges when we were studying time to event outcomes. So we said if they had two events that were less than 30 days apart, which showed an escalation in care, we're going to call it a single event and call it the time of the first event. So in this cohort, we extended our cohort time and was able to really rebuild the cohort and get up to 76,000 SGLT2 users. I'll just point out here, 50% of them are ever smokers. 40% of them had alcohol mid-use or alcohol misuse, and a really small proportion had underlying peripheral artery disease and ever had prior amputation. So really 0.5%. So when we look at the rates of the composite, SGLT2 was more likely to have 11.2 events per 1,000 person years versus DPP4 at 10. And that was pretty universal in both the amputation bucket and in the revascularization bucket. So as I mentioned, in this case, informative censoring or loss to follow-up is really not random, which is one of a key assumptions for survival data, is that censoring is non-informative. So if a patient is using SGLT2 and they're admitted for an ulcer, the medication can be stopped. And that changes your exposure outcome relationship. And so we had mentioned in our earlier design of, target trial emulation studies, is that we were looking for the biologic effects. So we said, well, what if there's really a prolonged outcome? So even if you stop the medication, so that the impact of that medication continues on past use of that SGLT2, which would follow more of the intention to treat study design. So that's what we did. We did prolong the exposure window. We didn't censor somebody once they stopped the medication, and we continued to follow them out for events for the next year after they stopped the medication. And so in panel A, this is when we are studying the time on drug. In panel C, this is when we give them an added year to have an event, even if they're not on the medication. And so you can see by our hazard ratio, what that does is increase our exposure time misclassification, but we still detect events even when patients are not on drug. So these are, residual effects of using the medication. Panels B and D show competing risks. So the competing risk is that, based on what I showed you in the prior MACE work, that there are a lot of patients who have a survival benefit for SGLT2. So you're prolonging their life and allowing them more time to develop these peripheral artery disease events. So the dotted lines are the risks of death. And you can see SGLT2 has a much lower risk of death than the DPP4. But as you consider that, there's this subhazard distribution for the increased risk in SGLT2 for peripheral artery disease. So one of the things that came up when we were doing this study was, well, maybe there are certain groups of patients who are just driving this impact of peripheral artery disease. So we looked at two subgroups. The first were those who had an underlying history of peripheral artery disease or osteomyelitis. And you can see here, this is the full cohort. This is those without peripheral artery disease. These are those with peripheral artery disease and osteo. So you can see the effect is magnified a lot. However, it's still consistent in that SGLT2 is still more than the DPP4s. The other thing that came up was, well, there are people who use insulin and they may be further in their severity or their degree of diabetes. So we stratified by those who were insulin users versus non-users. As you can tell here, the results are still consistent where SGLT2 use, even among those who don't use insulin, there's a higher rate of those peripheral artery outcomes. Okay, so our limitations. We have active users of the VA was the inclusion. So that's 95% of the cohort are men, and they're predominantly Caucasian men. 5% of the cohort are women, but that female cohort is actually a lot more diverse. We had to truncate follow-up at 4 years because the data gets sparse after 4 years. And we don't really have a lot of time for accruing the cohort and time on drug after FDA approval of SGLT2s. So there is always residual confounding and unobserved bias because physicians have their preferences in what they want to prescribe. And the medications are still considered relatively new. Our longest follow-up was about 5 years. Finally, we only examined these as second-line therapies, not among people using this as a primary strategy for their glucose control. But we have one of the largest sample sizes of users. Our data is linked to CMS and NDI, which is really valuable in complete capture of events and exposures. We use the trial emulation design, and that allows us to evaluate multiple exposures and outcomes in a temporal relationship with really extensive covariate adjustment. Patients are censored if they no longer use the VA or if they change medication. So because we use this passive data collection, there's a high retention rate. And our results were really very compatible with a lot of the RCT results when they were stratified to those in the primary prevention cohort for MACE. So I'll tell you, we got a lot of hate mail when we published the MACE paper that showed that there was no SGLT2 effect for primary prevention. You have to remember that cohort was 20,000 people at the time, but it was still one of the largest cohorts. And I will tell you, we went back to the literature and we said, well, what data exists out there in the clinical trials? And what we found was one meta-analysis done by Dr. Zellniker that looked at GLP-1s and looked at SGLT2s in a multi-risk factor cohort, which is people with hypertension and diabetes, but without established cardiovascular disease. And all of those results were solidly null. So I think there was a lot of extrapolation from clinical folks about, well, they work for those with underlying heart disease. Why shouldn't they work for those without heart disease? And I said, well, I'm just showing you what we found. The GLP-1s definitely work for those without underlying heart disease. And is that just because we had longer follow-up and a better sample size in that cohort? So 5 points to take away for clinical practice. Looser A1C goals is advisable for a lot of patients with comorbidities. If you escalate medications, consider heart risk, age, and comorbidities. The add-on therapy should preferentially use the newer agents because they are good agents, but you really do have to consider the costs and the data that we have, which is SGLT2 is solidly an important medication for heart failure reduction. GLP-1 is an important medication for weight loss and mortality reduction. For a PAD perspective, you should assess risks and be cautious with those patients. They do live longer, but then they have this increased risk for PAD. So 5 points to take away for study design is clinical trials are the gold standard, but they have limitations when applying to practice because our patients that we see day in, day out are not typical for what's recruited in clinical trials, and we are often extrapolating that data. Observational data can be used to emulate trial design. Think about your eligibility. Think about a clear point where randomization would occur. Align eligibility, treatment assignment, and the start of follow-up. You balance based on observed covariates, and then think about your causal inference approach justifications. So are you using an ITT approach, or are you evaluating the biologic impact of the intervention? Think carefully about your recurrent events or intercurrent events because that may change your exposure outcome relationship. So I will give you a brief glimpse into what we're working on now, which is a three-way comparison of DPPs, GLPs, and SGLT2s to reproduce the FLOW trial. We're excluding those with a GFR of less than 25, and we're evaluating for risk of kidney disease outcomes, including end-stage kidney disease, dialysis, renal transplant, or what we term a GFR event, which is a 50% reduction in the estimated GFR, which is confirmed to be a sustained reduction between 1 month and 1 year after the first decline.
Thank you so much, Dr. Roumie. It's so good to see you. This is Rosette. Sorry, I don't know if you can see me.
Hey, Rosette. How are you?
I'm well. Thank you so much for joining us for this talk. Sorry I wasn't able to jump out of clinic or get my AV working properly from there at the beginning, but it's such a pleasure to have you today, and I'm so glad you were able to share your findings with this group. I asked Wendy if I could jump in and kind of help out with questions so we could get through the pop-ups. First one you had was, did you exclude veterans who obtained their initial SGLT2 inhibitor and GLP-1 receptor analog prescriptions from community care providers?
So that's a great question. Because we have all the Medicare data and Part D data, we can also track prescription persistence through that. So we did not exclude Part D. But if you got it, let's say you're 45 years old and a veteran with diabetes and you have private insurance, I don't have access to that. So you would appear as a non-user in that cohort.
Great. And then we did have a follow-up, another question. On slide 43,
Oof, slide
about
43. All right, let me go back.
these slides on peripheral arterial disease and SGLT2 inhibitors, any association with worse renal function?
So that is what we are looking at now. The association with renal function, I think I just gave you a little teaser about it. SGLT2s do appear to be the most protective for renal function. It is very curious. Nobody has really come up with a really brilliant mechanism of action for why SGLT2s cause amputations or have this increased risk of peripheral vascular disease. There's been some batting about of mechanisms like, well, it's relative hypovolemia. But then you would expect worsening of kidney function, right? Not improvement. So I don't know that we have a really good idea for why the peripheral artery disease amputation is a signal. And it has been a fairly consistent signal with canagliflozin. I'll tell you, our cohort is 90% empagliflozin. So I think it may still be a class effect. Again, our group of veterans that we study peripheral artery disease in, they are not your clinical trial patients, right? They are 70-something years old. They've had diabetes for 10 years. They have a terrible A1C. It's like 9%. 50% of them are smokers. Most of those people would not have been eligible for the clinical trials.
I think those were the first few questions that came in. I'll ask a question of my own, which is to ask you about the GLP-1 receptor agonists in the VA population.
Mm-hmm.
Have you all had the same issues with supply problems contributing to adherence concerns?
Yeah, so there are still supply problems, and the GLP-1s in the VA do have some restrictions around them. So even though it's a fairly good-sized cohort, like when we studied the MACE, it was bigger than the SGLT2 cohort. That's now flipped. When we look at later years of data, SGLT2s are non-restricted anymore, and the GLPs are still restricted. You can't use them for weight loss. They can only be used for diabetes. You have to have failed a number of other drugs or be using it as second and third line therapy. So we do get a lot of people who are leaving the VA to get it through their Medicare benefit because they say, well, Medicare will cover it. And then they're getting it from Walgreens or wherever they can find it. So I think there are still restrictions. There are still, it is interesting. I would call it cost-related non-adherence that we see very nicely in both the Medicare and it's in the Medicare data primarily, not the VA data, where you get, you follow a patient along, they're filling their meds, their GLP, January, February, March, April, May, somewhere around July, they hit the donut hole and their adherence comes down to 0 and it looks like they're non-users anymore. Then the next January, they're back on and they might be using it a little bit longer. So, there are very nice patterns of cost-related non-adherence that we see related to all of these medicines, but it's more prominent with the GLP-1s.
I guess with that, part of the reason I wonder about that also is that it makes you wonder, could you use something like weight that's also being tracked at the same time to kind of tell you, is this for real, or did they wind up going somewhere else and getting it?
It's a great thought. And we've had these like internal discussions like in our own research group, because once you stop a GLP-1, there are legacy effects, right? If somebody's lost 20 pounds,
yeah,
you still see metabolic improvement in that person for
Right.
a long time. And,
Right.
and even though we are quote unquote censoring you, you still have benefit
Mhm.
that may not be the same when, like, some people don't like the fact that we use DPP-4 as a comparator. The problem is, it's considered cardiac neutral. Its costs are similar. For the comparator to SGLT2, they're both oral. So it's kind of a decent comparator. Like, it's just harder to kind of track those long-term consequences, especially of something like SGLT, or I'm sorry, of GLPs, where there's kind of metabolic improvement that lasts far beyond the time you actually use the drug.
Yeah, it's a great point. I think because in my brain, it sometimes gets stuck with like okay, we stop, and then when we restart, we might go back to the beginning dose, kind of it kind
Yes,
of wiggles the line way more than what we think about drug exposure.
exactly. Exactly. And this was some of the problems that we had when we first started studying insulin. We're like, somebody does this, somebody does this, somebody gets 3 bottles for 3 months, somebody gets 1 bottle for 3 months. Like, how do we track that exposure over time? And I think we finally figured it out, but we vary some of the rules because of that.
Yeah. If no further questions, thank you so much again, Christiane. It's so nice to just see and hear from you. And thank you for sharing this with our group over here. And I think if anyone has any follow-up, please feel free to email Wendy or I, and we can get you in touch with Christiane if needed.
Yep. Thank you so much.
Take care. Thanks.